are going to discuss a hospital-based study on combination of brinzolamide timolol versus dorzolamide timolol in glaucoma. Glaucoma, a group of disorders characterized by chronic progressive optic neuropathy resulting in a characteristic appearance of optic disc and a specific pattern of visual field effect that are frequently but not invariably associated with raised IOP. Normal IOP ranges from 10 to 21. Ocular hypertension treatment study and collaborative initial glaucoma treatment study shows that 50 to 75% of patients require combination therapy at some stage of the disease and may need 2 or more drugs to achieve target pressure. A fixed combination has various potential advantages: no risk of dust washout, reduced exposure to preservatives with reduced side effects, reduced treatment cost, better patient compliance, and quality of life. Previous studies like Mani et al. And Holo et al. Have found that brinzolamide timolol and dorzolamide timolol have almost similar efficacy at lowering IOP. The purpose of this study was to compare the efficacy of IOP reduction and patient compliance of brinzolamide 1% plus timolol maleate 0.5% fixed combination and dorzolamide 2% plus timolol maleate 0.5% fixed combination in a hospital-based population with primary open-angle glaucoma or normal tension glaucoma. We did a prospective randomized controlled clinical study. 86 eyes of patients with primary open-angle glaucoma or NTG were randomized to receive either brinzolamide timolol or dorzolamide timolol. 43 eyes in brinzolamide group and 43 eyes in dorzolamide group. Male or female of 18 years, above 18 years of age are included, who were clinically diagnosed of POAG or NTG, who were uncontrolled on a single or a double medication other than the eye drops we studied. Exclusion criteria were active ocular disease other than glaucoma that would interfere with study outcomes, sensitivity or allergy to any component of either study drug, pregnancy, planning a pregnancy or breastfeeding, functionally marked visual field loss, ocular surgery within last 3 months, concomitant uses of ocular drugs except intermittent use of artificial tears, active systemic disease or plans to change ongoing systemic treatment that might affect IOP. Diabetic retinopathy were excluded. IOPs were measured at baseline 2 weeks, 1, 2, and 3 months. Main outcome were measured the mean change in IOP from baseline at every visit. Secondary outcome measures included tolerability of each fixed combination. Baseline and follow-up visit evaluations included medical and ophthalmic history and a complete ophthalmic examination. Study drug was initiated after examination and randomization. Patients were asked about the adverse events and compliance, and the response were recorded. We have the results as mean IOP reduction percentage from baseline was 26% and 44% at 2 weeks, 26% and 45% at 1 month, 27% and 46% at 2 months, and 28% and 46% at 3 months with brinzolamide timolol and dorzolamide timolol respectively. Better tolerability and compliance without any adverse event was seen in 83.72% in brinzolamide timolol group and in 32.55% in dorzolamide timolol group. Tolerability of brinzolamide timolol and dorzolamide timolol with reference is given here. No adverse event in 14 patients in dorzolamide group, ocular discomfort in 10, ocular pain in 10, and blood vision was seen in 9 patients in dorzolamide group. Whereas no adverse event was there in 36 patients in BT group, ocular discomfort in 5, pain in 2, but no blurring of vision. According to ocular hypertension treatment study and collaborative initial glaucoma treatment study, more than 50% patients require more than 1 drug to reach target IOP. Reducing the amount of drops by including more than 1 medication is in fixed combination will reduce side effect and increase the compliance. Although tolerability is identified as a barrier to compliance, issue of efficacy needs to be carefully investigated. The purpose of our study was to compare the IOP lowering effect of both the drugs and with patients as primary outcome with patients' tolerability as secondary outcome. In our study, we found that both BT and DT significantly reduced IOP at study visits, but there were lower mean IOPs from dorzolamide group than brinzolamide group at all the study visits, significantly at 2 weeks. Mani et al. And Holo et al. Also compared BT and DT, but they only compared the efficacy, not tolerability. Regarding the tolerability of drug, beta blockers component of 2 carbonic anhydrase are similar, so any dissimilarity is due to the pH. DT has an acidic pH and BT has physiological pH. The present study shows that BT and DT provide effective lowering in IOP. Both fixed combination provide effective IOP lowering, but tolerability was bettered with brinzolamide group. And DT is more appropriate therapeutic choice for IOP lowering than BT for patients in need of more than 1 eye drop. Thank you.